You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about coronary arteries. The first half will focus on normal coronary artery anatomy. The second half will focus on anomalous coronary anatomy. Let's start with normal coronaries. The normal lengths of the main arteries are 12 to 14 centimeters for the right coronary artery, 2 millimeters to 4 centimeters for the left main artery, 10 centimeters to 13 centimeters for the LAD, and 5 to 8 centimeters for the circumflex. Let's start with the right system. The branches that arise from the RCA are as follows. The conus arises from the first branch as the first branch in 50 to 60% of the cases and supplies the RV outflow tract. Next, the sinoatrial artery originates from the RCA as the next branch in 66% of cases. In 34% of the time, it originates from the left circumflex, and it passes posteriorly around the superior vena cava to supply the sinus node. Next, there are two acute marginal arteries, AM, which are long branches that define the cutoffs for the proximal, mid, and distal RCA. Some textbooks will call the higher acute marginal branch the RV marginal branch, and the lower marginal branch simply the acute marginal branch, even though it also supplies the RV. Other textbooks will number the acute marginal branches as 1 and 2. How do you define proximal versus mid versus distal RCA? The proximal RCA extends from the ostium of the RCA to the first of the upper acute marginal branch, also referred to as the RV marginal branch. The mid RCA is a segment between takeoffs of the first and second, or the upper and lower acute marginal branches. The distal RCA extends from the takeoff of the lower acute marginal branch to the origin of the posterior descending artery. After the distal RCA gives off the posterior descending artery, it continues on as the right posterior atrioventricular artery, which can give off the first, second, and third right posterior lateral arteries. The interventricular septum is the most densely vascularized area of the heart, supplied by branches of the LAD that interconnect with septal branches of the PDA. A shepherd's crook RCA refers to an RCA that has a normal origin from the RCC, the right coronary cusp, but with an acutely high and tortuous course in the proximal segment. It has no pathologic implications, but just makes PCI more challenging to do. The prevalence of shepherd's crook RCA is 5%. Now we'll go to the other side on the left system. The left main coronary artery arises from the superior portion of the left aortic sinus. The left main usually bifurcates into the LAD and the left circumflex, or LCX. About 1/3 of patients will have a ramus branch of the left main. How do you define proximal versus mid versus distal LAD? The takeoff of the first diagonal marks the transition point from the proximal to the mid LAD. The takeoff of the second diagonal marks the transition point from the mid to distal LAD. Some textbooks alternatively use the first septal and third septal to define the transition point from proximal to mid LAD and mid to distal LAD. Others define the transition point from the mid to distal LAD as the halfway point from the takeoff of the first septal to the apex of the heart. I don't like the latter system because it is more subjective. The first and second diagonals are long and unmistakable landmarks. I would use the first and second diagonal base definitions. How about the LCX? How would you define proximal versus mid versus distal circumflex? The takeoff of the first obtuse marginal artery marks a transition point from the proximal to the mid circumflex. The takeoff of the second obtuse marginal artery marks a transition point from the mid to the distal circumflex. Now that we have a handle on the normal coronary artery, let's talk about the different kinds of anomalies you can have with coronary arteries. Coronary artery anomalies, or CAAs, are quite rare, occurring in 1.3% of the population, but not so rare that you would not see it in your general practice. The most common coronary artery anomalies with no clinical significance are separate origin of the right conus artery, separate ostia of the LAD and the circumflex, and origin of the left circumflex from the RCA, or the right sinus of Valsalva. Those are the most common anomalies with no clinical significance. On the other hand, sudden cardiac death can occur from abnormal LCA off the right coronary sinus, which is less common than the right counterpart, but more sudden cardiac death will occur here. Abnormal right coronary artery off the left coronary sinus, abnormal left coronary artery from the pulmonary artery, and abnormal right coronary from the pulmonary artery. So just remember these four, okay? These are the ones that give you sudden cardiac death. Let's start with anomalous aortic origin of a coronary artery. That's AAOCA. It can be ALCA-R or ARCA-L, depending on which side you're talking about. AAOCA, anomalous aortic origin of a coronary artery, which it refers to contralateral or non-coronary sinus origin of a coronary artery, and occurs in 0.1 to 0.3% of the population, but is responsible for 4 to 14% of sudden cardiac death in college athletes, so it must be considered seriously. Anomalous origin of the RCA is present in 2% of patients undergoing angiography. Anomalous origin of the circumflex is present in 1% of patients undergoing angiography. When a coronary sinus originates from the opposite sinus of Valsalva, there are 4 possible anatomic courses it can take to get to where it needs to go. A. Anterior to the pulmonary artery. B. In between the aorta and pulmonary artery. C. Posterior to the aorta. And D. Into the interventricular septum and crista supraventricularis. Out of the above 4 paths, the path that courses in between the aorta and pulmonary, which is called interarterial or intramural, has the greatest risk of sudden cardiac death, since it is most at risk for being physically trapped and compressed. In addition, an LCA, a left coronary artery, coursing between the aorta and pulmonary artery, has a higher risk of sudden cardiac death than an RCA, a right coronary artery, coursing between the aorta and pulmonary artery, likely due to the larger degree of myocardium perfused by the left coronary artery. Sudden death from anomalous aortic origin of a coronary artery is more likely to occur during exercise than at rest. In all of the above cases, the abnormal coronary artery can have an intramural segment or no intramural segment. The current guidelines suggest that if the patient with anomalous aortic origin of a coronary artery has ischemic symptoms or is found to be ischemic by stress testing, surgical intervention is warranted. That's a class 1 recommendation. In the absence of ischemic symptoms or ischemic findings on stress testing, surgical intervention can still be done for ALCA-R, which is anomalous left coronary artery arising from the right, class 2A, or if there are ventricular arrhythmias in ARCA-L, which is anomalous right coronary artery arising from the left. If ARCA-L, which is anomalous right coronary arising from the left, has no ventricular arrhythmias and no ischemic symptoms or findings, then surgical intervention and continued observation both have a class 2B recommendation. Put another way, anomalous left coronary artery arising from the right cusp should undergo surgical intervention regardless of whether there's ischemia, class 1, or no ischemia, class 2A. Whereas anomalous right coronary artery arising from the left cuff should undergo surgical intervention if there is ischemia, class 1, or ventricular arrhythmias, class 2A. Now, let's move on to anomalous origin of the coronary artery from the pulmonary artery. That's ALCAPA and ARCAPA. ALCAPA, which is anomalous left coronary artery from the pulmonary artery, is also known as Bland-Garland-White syndrome. It is a rare disorder that usually presents as congestive heart failure in infancy, but can also remain undiagnosed until adulthood if significant collaterals from the RCA to the LAD and circumflex develop. Anomalous right coronary artery from the pulmonary artery, or ARCAPA, is even rarer than ALCAPA. When ARCAPA is present, perfusion of the normal RCA territory is dependent on development of collaterals from the left coronary circulation. In either situation, when an anomalous coronary artery arises from the pulmonary artery, regardless of left or right, that coronary artery is not actually being perfused by the pulmonary artery. Instead, the coronary artery is perfused retrogradely via collaterals from the contralateral coronary artery, then drains into the pulmonary artery. Therefore, that normal contralateral coronary artery will be quite prominent and dilated because it's taking on the flow needed to supply both sides of the heart. Should surgery be pursued in ALCAPA, ALPACA, and ARPACA? Yes, definitely. It is a class 1 indication for ALPACA regardless of symptoms, and it is a class 1 indication for ARCAPA if there are symptoms. Again, for anomalous left coronary artery arising from the pulmonary artery, it is a class 1 indication regardless of symptoms, and for anomalous right coronary artery arising from the pulmonary artery, it is a class 1 indication if there are symptoms. Now, I'll briefly touch upon myocardial bridge. A myocardial bridge results when an epicardial coronary artery dives intramyocardially for a variable length and results in some degree of compression during ventricular systole. 80% of cases involve the left anterior descending, and it is estimated that this phenomenon may be present angiographically in up to 25% of cases. On angiography, a focal narrowing is typically seen with a smooth appearance of the vessel that is noted only during systole. Fortunately, myocardial bridging tends to have a benign course and patients are usually asymptomatic. Next is coronary artery fistulas. The most prevalent hemodynamically significant congenital artery anomaly is coronary arteriovenous fistula. When the coronary arteriovenous fistula's drainage is into the coronary sinus, superior vena cava, pulmonary artery, right atrium, or right ventricle, a left-to-right shunt is created. When present in infancy and childhood, they often come to attention because of a loud, continuous murmur. Half of patients with congenital coronary artery fistulas are asymptomatic, but half of them develop heart failure, aneurysm, rupture, or ischemia. That's a wrap for this episode on normal and anomalous coronary artery anatomy.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.